Okay. All right. Well, I want to welcome you all to our MBC March 2024 presentation with Dr. Alison Conlin. We're so happy to have her here today and that all of you could join us. She is the medical director of the breast cancer program of Providence Cancer Institute Franz Clinic. And I will go ahead and read her quote. We aim to care for our patients with the utmost respect and compassion while offering the most advanced treatments and options to participate in new and exciting clinical trials. Our focus is always on the patient and helping them and their family members feel the complete care they are receiving. Dr. Conlin's interests are in both early and advanced stage breast cancer and the development and incorporation of new drugs for these patients. She sees patients in Portland, Oregon. And Dr. Conlin, I'll allow you to get your slides up so that you can start the presentation today. And I'm just again, very happy that you all could be here. And thank you so much.
Yeah, thank you. Hope everybody had a nice social hour and got to visit with each other and hopefully have a little Grubhub or DoorDash or something you can be snacking on after this beautiful but chilly sunny day in Portland. I am excited to chat with y'all about some of the things we learned about in San Antonio. As many of you might know, San Antonio Breast Cancer Symposium has been going on for, I didn't look, 50 plus years, a while, and it's grown quite a bit in a meeting at AACR, the American Academy of Clinical Research, also joined in on co-sponsoring the meeting, but it's always in San Antonio and it's always in December. And it is really a very global meeting where people from all over the world come to learn about breast cancer. And it's just very highly regarded as the best breast cancer meeting, certainly for medical oncology all year. And we all look forward to it, even though it's time away during a busy season. It's where we kind of learn new things and kind of get to interface with the people we want to interface. And so there's always really great, exciting new presentations. Some of them are actually practice changing, meaning this will be something different I do on Monday. Some of them are just really exciting because it's what's on the horizon. And some of that is what I wanted to bring to you because I know, especially those with MBC are really trying to think about what is the next thing? What should I be looking for? What is the really big hope that's coming maybe for my type of breast cancer? There's also a lot of really great presentations. I'm going to share a little snippet on other types of research that happens around breast cancer. And that's always actually been a passion of mine as well, like, exercise for fatigue during chemo, or, is it really a real thing that lymphedema happens, from doing blood draws on your arm? People kind of looking at some of the other parts of breast cancer care with a very research focus. And there's a lot of discussion that happens at the meeting. So hopefully we're going to have some time to chat. And if people have questions about some of the other things, I really tried to focus my slides to have more time for discussion. So just to go over, hopefully I can move my slides. What? Try to go back with this. Am I in? Okay, there we go. How did I get out of slideshow real quick? Goodness gracious. Bigger. Before we practiced before. Just open it one more time. Sorry, everybody. I know I had a roll going. Start slideshow. This goes again. Okay, maybe that will. There we go. Okay, so just to kind of go over my agenda would be to talk about a few statistics and facts, because that's always important when we're talking about breast cancer. And then kind of the meat of the talk is a little bit about some of the studies, some updates from this past December, a little bit about how we do our research at Providence, not anything exhaustive, and a few slides on living with metastatic breast cancer, and then time for questions. Still didn't want to advance. Okay, there we go. So this is from the 2024 released American Cancer Society report that, just came out last month, looking at kind of estimated cases that would happen potentially this coming year. This is the estimate of what they think is going to happen in 2024 based on trends in 2023 and years prior. And of course, breast cancer is still the #1 cancer in women in this country, but also in the world. This is looking at this country that there's an estimate of 310,000 plus women who will get a diagnosis of breast cancer this coming year of any stage. That is by far more than the lung, colon, and uterine combined. It is, you know, a third of all cancers that will happen in women will be a breast cancer this coming year. Just kind of incredible. And, you know, it speaks to kind of how common this is when you talk to people. Everybody knows someone who's had breast cancer, and most people know several people because, you know, it's such a common thing. In terms of cancer deaths, that's on the bottom. It is the second most common cause of cancer death every year, with 42,000 plus women estimated to die this coming year of breast cancer. So it just trails behind lung cancer, which is the deadliest cancer, but is still such an enormous amount of women per year that will die of breast cancer. And so this always underscores our, you know, need and our desire to keep doing better, to keep improving survival, to keep thinking about prevention and treatment, and sort of how we're going to help these women that and men actually, although mostly women that will have this challenge this year, have this health outcome for them. So some of the facts and figures. The 2024, we talked about the 310,000 women and the 2,700 men that will be diagnosed with invasive breast cancer. So of course, men get breast cancer, not nearly as common. And we know that early stage matters, that 5-year survival rates can be greater than 90% in early stage. However, looking at 5-year survival rates, we know in breast cancer is not such an accurate statistic. And the next slide will show us that, because recurrences happen certainly after 5 years, if not even after 10 years. And I'm sure many people on this call can speak to their experiences and how that happened. And of course, I see that in a lot of patients. And of course, not on this slide, but there are a large percentage of women, not more than 10%, but a percentage of women, I think it's 6%, that present with stage 4 at the same time as their breast mass is found. So they just sort of have de novo breast cancer. And we're starting to look at that as well as maybe a separate entity in terms of drug development and things. So survival rates for MBC can vary based on lots of factors, of course, the stage of the cancer, but also the subtype. You'll hear me talk a lot about, you know, this was for the hormone positive type, this was for the HER2 positive type or the triple negative type, and other personal health factors, other things that might allow you to do certain treatments or limit what treatments might be safe for you. Breast cancer is treatable at any stage. That was a mantra that I was taught very much in my training at Memorial Sloan Kettering, but treatments for metastatic breast cancer are also improving. So, you know, if cancer's the answer, tissue's the issue, and if it's not curable, it's treatable. So we do have lots of treatments for patients, and we talk about that. And we're really trying hard to improve both quality of life and quantity of life. So many of our studies do look at quality of life. And I think that's something people think we don't do, but we really, really do want to look at that, and not just kind of look at numbers, but also look at what is the time like for women when they're doing a certain treatment. So this looks at sort of between 2013 and 2019, what we estimated for localized means not node positive, regional means a node positive, and distant means metastatic at 5 years. How are women doing, or how are patients doing with breast cancer? And localized, most patients at 5 years are doing well. Regional, node positive, most women are still doing well, 86%. Distant, not nearly as many people alive at 5 years. And that's kind of starting to be outdated. If you combine it all together, it does look quite good. At 5 years, people are 91%. But the pink part of the slide just sort of speaks that at 10 years, the number can be down to 84, and even at 15 years, 80%. So we know we're having people live a long time, but there's a desperate desire to keep, those numbers even higher, given that they're not all 100%. Women being diagnosed now have a better outlook than even these numbers. I find these numbers to be very difficult. And of course, we're asked a lot about these numbers, and it's really hard to know because there's so many different experiences that happen and so many different factors that you just can't even make a list of that. But it still helps put in perspective where we're at in terms of our urgency to have new drugs approved. So the things I wanted to talk about, again, I wanted to limit sort of what I talked about in scope of studies. And when we present these studies to ourselves, like when we have a journal club, we'll show like 15 slides, because we'll look at like the nitty gritty of like the side effect profile or the actual, response rates versus the other outcomes. But here I really wanted to keep it high level, because I feel like that's really the most impactful, to really talk about what was the thing that really meant the most to us when we were looking at a study. There was a big study called the HER2 Climb 02 study. We participated in that study, and I have known and worked with this kind of group and this drug for a long time. So I thought that was an important one for HER2 positive breast cancer specifically. We'll talk about the brain metastases and HER2 positive breast cancer. In hormone positive breast cancer, that is to say estrogen receptor positive breast cancer that doesn't have the HER2 usually, there were two interesting studies, the Tropion or one, which previously had been first looked at the ESMO meeting which is European Society of Medical Oncology in October. And then they kind of had a second presentation here. Had to change it a little bit because otherwise you're not allowed to do it at the same meeting, but they wanted to get a better audience here at San Antonio. And that was impressive. And this Anavo 120 study was kind of a late breaking study. It was kind of presented at the very end by Dr. Javeri from Sloan Kettering, and was actually a very impressive graph to look at. And I thought, ooh, that's something I really want to keep my eye on. It just kind of surprised me. And then there was a really cool session I went to on quality of life. And this one particular speaker, he's worth following on Twitter. He's worth looking up and Googling and finding any kind of talk he gives. I thought I would highlight a talk he gave that I really, it moved me as like a doctor in research, thinking like, we really do have to think about these things a little differently. And so I wanted to present a few slides of his. So the HER2CLIMB-02 study, there was this HER2CLIMB-01 study. That is the study that approved tucatinib or Tukysa for metastatic HER2 positive breast cancer. And that was in April 2020. I believe it was right during shutdown that they got their approval, and the presentation had been just prior in San Antonio 2019. But HER2CLIMB-02 was kind of their second big study. And what they were looking at in this study was 460 patients, and they were randomized 1-to-1, meaning, it was equal in both groups. And randomization means like you didn't have the choice. They flipped the coin, but you did not, in this case, know what you were getting because it was placebo controlled. So everybody was getting a standard treatment called TDM1 or Kadcyla, and then everybody was getting a pill, and they weren't sure if it was a placebo or tucatinib, the drug that had recently been approved. But this combination was the question. It had been approved in a different combination, and they were looking at patients who had HER2/neu positive or HER2/neu overexpressed, so that's either like 3+ or FISH positive, metastatic breast cancer that had standard first treatment. The standard first treatment for that is a taxane, like Taxotere or Taxol, with Herceptin or trastuzumab, and usually in our country, pertuzumab or Perjeta. And people had done that. It had worked for some amount of time or not, and then it wasn't working anymore. So that's what they mean by it. It was HER2 positive progression after trastuzumab taxane. So they wanted people to be getting on their second chemo with HER2 therapy. And they wanted them, they didn't exclude them if they had brain metastases. And this was kind of the big deal in HER2CLIMB-01, is they included patients who had not just treated stable brain metastases, but patients who had untreated brain metastases or progressing after treatment brain metastases. People who we had typically in many, many other trials had said, oh, you got to go take care of that, or we don't want to put you on our trial. They were so confident that this tucatinib had CNS penetration or treatment up in the area of the brain that they wanted to actually have those people in the trial. And so again, like HER2CLIMB-01, they included those patients in HER2CLIMB-02 because they knew even from HER2CLIMB-01 that was a good idea. So patients were getting standard second-line time therapy, which is TDM1 or Kadcyla. That's an antibody drug conjugate. They were getting that IV every 3 weeks, which is standard, and everybody got that part. And then it was just does this oral targeted HER2 tyrosine kinase inhibitor help make that work better, particularly in the patients who had brain metastases. And the primary objective of the study was looking at something called progression-free survival. That is to say, how long can you stay on this without having the cancer grow someplace definitively that shows resistance? Secondarily, of course, they were looking at overall survival, like how long do people live in both arms in general, and how do patients specifically in the brain metastases group do, and how much response is there. So they were hoping, they were going to have 460 women or people. They were going to plan it after a certain amount of events. And Dr. Hurwitz presented this because that had all happened. And like I said, we had a few people on this, which made it exciting to see the final results. So this was the final result. This is the main slide that kind of showed you, this is what we asked the question, and what it's showing is the blue is the people getting the tucatinib and the purple is the people getting placebo. And it's better to be a higher graph because it's the sort of over time on the bottom, what's your likelihood of not having the cancer be progressive or moving. So sometimes people look at like, what is the 50th, like when do half of people have the cancer not progressing? How many months is that? And that is 7.4 versus 9.5. So on average, people do about 2.1 months better if they get to catnip with the TDM1 instead of just TDM1 alone. So, and then the statistics on it show this little hazard ratio is 0.76. How you do the math on that is that a negative, like a less than one number is good. So that means it's 25% better. So adding to catnip is a 25% improvement in progression-free survival. So this was definitely a statistically significant positive study. 2.1 months doesn't sound like a lot, but it's definitely better than a half a month or nothing. And then they wanted to look more specifically at other groups. And that here is the brain metastases group. So it looks even better in the brain metastases group. If you look at that kind of 50th percentile, again, it goes from 5.7 to 7.8 months. It's still 2.1 months, but they're smaller numbers because these patients have more, more risk to them. And so again, that statistical thing made it's a third better to get it. So this was a really good combination. And I didn't show the side effect slides, but it adds a little bit of side effects, but not a lot. And so generally this was interpreted as a very positive study and that this could be a good combination to use. So other things that were presented at this time was we talked a little bit after this presentation about other things that you might want to give for brain metastases. And many people who have HER2 positive breast cancer, and even those who don't, know about this drug called trastuzumab deruxtecan. This is HER2. This is the antibody drug conjugate that is a trastuzumab with a different kind of chemo linker than that Kadcyla. And this drug had previously beat out TDM1 quite handily in the DB-03 study, which had recently been kind of published and shown. And so at ESMO, that meeting in Europe, they had a pooled analysis, a poster of all the different studies that patients may have brain metastases and get this drug, because they did not include as many brain metastases people. They did the typical thing where in their big study approving trastuzumab deruxtecan against Kadcyla, they made a big caveat and said you had to have like treated brain metastases. But here are these little small studies, 15 patients, 13 patients. These were examples of people, and these are called waterfall plots. And to be a negative thing means response. So all these people are showing these great intracranial response rate of 70%, intracranial response rate of 70%, intracranial response rate of 40%. So they're saying, even though we didn't include those people, we could have. Actually, if you look back in enough of our studies, this drug also works in the brain. So I think this was just the way, trastuzumab deruxtecan was trying to sort of show it also can work. They haven't done as much work as the tucatinib specifically focusing on that population, but I think we're starting to find out in our real world practice that this drug also works for brain metastases that are HER2 positive. So that was kind of a big one. We always really like seeing HER2 positive studies, especially in brain metastases. And what that led to is this final kind of discussion slide I'll show, is that should we have a little bit of a paradigm shift, or how do we sort of think about the algorithm? That's kind of what is our general guide to treating metastatic HER2 positive disease. Again, that first line is still a taxane with trastuzumab and pertuzumab. There are some studies challenging that trastuzumab deruxtecan definitely has slid into that second slot because it did beat out the TDM1. But maybe if you have some CNS disease, if you have brain metastases or other leptomeningeal disease, maybe tucatinib is a better option, and you could either give it with TDM1 or its approved HER2 regimen, trastuzumab and capecitabine. But that's kind of the new idea, is when you give the TDM1, do you want to have the tucatinib? It's almost like these two tucatinib studies compete with themselves. That's one of the things that the company kind of struggled with, because they both have positioned themselves not quite against TDXD, but kind of after. But it's still a great option, and clearly really good if you have the CNS disease over here. So I thought this was a good summary. This always helps us providers when we get something that's potentially practice changing. We're like, how does it fit into our practice? Who does this good for? How do we do this? And this is how we think about that. And I was impressed with this whole presentation. So I know there'll be questions, but we can kind of tackle them at the end if you don't mind. To get to kind of a different part, to look at some of the hormone positive studies, this Tropion Breast 01 study was a very interesting study too. And like I mentioned, this had been previously a little bit shown, but Dr. Bardia from Mass General presented, and this was a randomized phase 3 study. Open label means you know what you're getting. And it was a global study, and it was large. It was 700 plus women. I don't think that's on this slide, but you'll see it on the last slide. And patients had had metastatic hormone positive, but HER2 negative, and negative they just meant could be 0, 1, 2 plus. They didn't really care about HER2 low. And they had had previous chemo, so hopefully they'd had at least 1 or 2 chemos. So it wasn't really a very upfront study, but it was really realistic, patients who'd had lots of treatments, and hopefully they'd already had a hormone therapy as well. So they wanted them to, have tried the hormone therapy before they go to chemo. And they did something called stratification. They sort of wanted to balance in both groups if people had had the access to a CDK4 inhibitor, because this was such a global study. There are some countries where people still can't get that type of drug. But what they did was they randomized 1-to-1, and you either got the drug, which is called Dato-DXd. It's another antibody drug conjugate. And it's similar. The DXd is like the Enhertu. It's the same chemo, but it's a different antibody. It's not going to the HER2. It's going to the trope antibody, which is like sacituzumab. So this is kind of a drug that has like the antibody part of similar to sacituzumab, although not the same, and then the actual chemo part is the same as Enhertu. So it's a pretty interesting combo of things that we're starting to get used to in other antibody drug conjugates. They compared it to, you get to choose chemo of 4 choices. So ideally you pick something that patient hasn't done yet, and they picked either eribulin, vinorelbine, gemcitabine, or capecitabine, Xeloda. So it was a pretty wide open study. And then they looked at both the overall survival and the progression-free survival, as well as the response rate and safety and PROs. I'll show you a little bit of that, not too much. So these were the 2 main things. It too, you can tell by the graph, the separation means that the Dato-DXd, this purple one, did better than investigator chemo, and the 50% thing was 4.5 to 6.9 months. So it improved at about 2.5 months. And then the other thing they measured, which is kind of important, is time to subsequent, time to first subsequent therapy. When did you move on to the next chemo? Did you do this chemo and then immediately have to go to something else? Or did you do this chemo, take a break? Ideally it should be pretty similar, but it was about a 3-month difference. So I'm not sure if that means people needed a bigger break after, or they actually could get away with just cruising a little bit before they needed to go to the next one, or just worked for longer. So 5 months versus 8.5 months. And they looked at some pretty good quality of life measures, because they were trying to compare different side effect profiles. The Dato-DXd caused a lot more mouth sores, but didn't cause as much diarrhea or nausea as some of the other agents, and low blood counts. But they had some strategies for that, and they saw less grade 3 events, less dose reductions, interruptions, and serious adverse events with the Dato-DXd than standard chemo. And antibody drug conjugates can be like that. They can act like standard chemo, or they can have their own unique kind of side effect profile. And it looked like, again, higher, better quality of life over time with the Dato-DXd than that in regular chemo. So on his acknowledgments at the end, after his summaries, I had never actually seen a slide like this. The investigator, Dr. Bardia, who's just a lovely gentleman, his thanking of the enrollments, put 732 symbols on the slide to say this, represents the 732 women that participated on this study, which I thought to be a much better way to thank patients, is to sort of just visibly show us these are all individual people that participated on that. And I had never seen that before, and I personally thought that was a nice choice. That I'm not sure if he thought of that or how that came to be, but that was an interesting thing that happened at the meeting. So the other hormone positive study I mentioned that I thought was pretty impactful and interesting was this INAVO 120 study. And this was a study sponsored by Pfizer that was looking at a new drug, inavolisib. I don't even know how to say it yet. This is always the funny thing in oncology when we can't pronounce the drugs yet until you hear someone say it like 5 times, and I don't even, it may or may not have a branded name yet, but it's not approved yet, and neither is the last drug I was talking about, Dato-DXd, is probably at the FDA with that study. But this was looking at a pretty specific group of hormone-positive metastatic breast cancer patients. It was looking at patients who had PIK3CA mutation pathway. So it's one of the most commonly mutated pathways in metastatic hormone-positive breast cancer, but it's not even close to 50%. So it's not the majority of people, it's just one of the more common ones we see. And generally having a PI3 kinase pathway mutation is a more aggressive cancer. So they were really trying to find people that had this PI3 kinase mutation. They were hormone positive, HER2 negative, and they had measurable disease. So they could not just have bone disease, which is always a challenge to perform studies like that. So they, had maybe lymph nodes or lung lesions or liver lesions, and they had their cancer move or progress or be resistant within 12 months of finishing their curative tamoxifen or AI. So this is a role resistant population that they were going to look for. They did not want them to have any treatment at all yet for advanced breast cancer. So this was their very first treatment for metastatic breast cancer, and they'd had some other thing that they recently either were on or had just finished. And because these PI3 kinase pathways tend to have problems with high glucose, you had to not sort of have undiagnosed diabetes, like a fasting glucose of less than 126 and hemoglobin A1C of less than 6. So they didn't want unknown or untreated diabetes, which is hard because then that's, excluding a group of people. There is already a PI3 kinase inhibitor approved called Piqray, and that one does have a lot of problems with high glucose, and it is relatively non-specific, although alpha-specific PI3 kinase inhibitor. This drug is a little bit more specific, but still alpha-specific PI3 kinase inhibitor. It's just a different one. We've kind of been waiting for another one for a while. Alpelisib is the one that's approved, and many of us aren't that fond of it, and patients especially because of the side effect profile. And so we're hoping for a really good one, and this study kind of piqued my interest on that, no pun intended. So both groups, they were randomized. It was 325 women, so it was large but not massive, and it was randomized 1-to-1, so you either got one thing or the other. Everybody got fulvestrant, everybody got palbociclib, so a CDK4/6 inhibitor at standard doses with standard dose reductions, and then you knew what you got. You got either inavolisib or not, and they were looking really for survival, but also progression-free survival, but overall survival response rates. But this was the graph. Looks pretty wide. I don't think this is stretched out. I just think that's why this difference between the two was bigger than any of the other studies I'd seen at this meeting. And indeed, it sort of went from 7 to 15 months as that median kind of, the average 50% of people had at least 15 months with this combo as opposed to 7. And 7 sounds low, in most of the fulvestrant CDK4/6 trials, it was a little bit higher than 7. So they were again enriching for maybe people with more mutations or a more aggressive subtype, and the folks did even better than we thought. So 7 to 15 was a pretty big deal. It was more than a 50% improvement. And so I think they kind of fast tracked this data to bring it to this meeting to keep working on it. I'm not sure if they're going to FDA soon or not, but it was pretty impressive when they presented it. This was the overall survival already, again, even at this very early look, already started to look like almost statistically significant. And that's hard to do at your first presentation. So the summary was the addition of the inavolisib, novelisib, I think it is, to palbociclib and fulvestrant. So it's a triplet, showed a statistically significant and clinically meaningful improvement in progression-free survival. It's not just 2 months, it's like double. In people who have the PI3 kinase mutated, hormone positive, HER2 negative advanced breast cancer who recurred on or within 12 months of endocrine therapy. It's kind of a niche, it's not every patient we're going to see, but that might be a group of people we really want to give more therapy to. because they doubled the median PFS and the overall survival already looked good. And I didn't show you the safety profile, but it didn't add really, it wasn't nearly as bad as some of the side effects we've seen with the other PI3 kinase inhibitors. It looked better. So this was definitely the thing I walked away going, I'm really excited to hear more about this combination. I hope this starts getting, approval or used more. And I haven't seen anything since, but I am keeping my eye out. So I'll move to the final presentation I wanted to share. And this was this professor, Dr. Don Dyson. And I have the last slide, his kind of things to follow, but he's from Brown, and he is an interesting professor. And he had, he gave a talk that the slides didn't exactly go with the things he said. Like if you listen to what he said, it was actually better than if you read all the slides. I found that because I did both. But he was really talking about patient as partner and the importance of feedback. And he was talking about how we design our trials. And I'm sure every person who's listening to this talk is like, duh, of course we're your partner. Of course our feedback is important. But I think that we lose sight of that when we're getting really heavy in the research. So one of the things he talked about was the difference between reporting adverse events. Typically, when we talk about clinical research studies, we talk about adverse events. That's like how many people had nausea, how many people had a rash, how many people had low blood counts. Some of those are pretty objective, like low blood counts, but nausea is the nurse and me asking, did you have nausea or not, and then writing it down and then putting it into a spreadsheet. As opposed to something called patient-reported outcomes. Patient-reported outcomes are the patient filling out a diary each time that says, what happened to me? And he showed a slide before this one showing how very different they are and how the new term isn't adverse event reporting or patient-reported outcomes, it's patient-informed outcomes, or what he wrote here, patient-important outcomes. So, what's important is your patient informing you what's happening, and can we merge this? And he used this example of the Mona Lisa trials. These were the trials that approved ribociclib, the CDK4/6 inhibitor called Kisqali. And there was a few of them, and he kind of lumped them all together. And when you look at, this was a confusing slide, so what he said was better than what I'll try to tell you, but he was sort of looking at, as patients get older, the overall survival difference, how much more the ribociclib helps, actually gets smaller. It's there. It's still statistically, it's still 10 months, but it's not statistically significant anymore. And he's wondering, it's 16 months here, but it's 10 months here. He's wondering, what reasons are those? And when you look down here, there's actually, I didn't highlight it, he had a different slide, but 41% of patients over 75 dropped out due to adverse events in the group over 75, as opposed to 15%. So maybe we're only looking at the survival of patients who, aren't all getting the drug, and maybe they discontinued not because they couldn't get down to the right dose, because they chose not to take it. Like, how do we know why patients discontinued? Did they discontinue because they said, I'd just rather not do this at all? Or like, this is the discontinuing without a prior dose reduction. So half of them they didn't even try a different dose. They were like, I don't want to do this at all. And we've all, well, I've certainly had this experience with my patients where they like try something once and they're like, I don't really want to try it at a different dose. It just doesn't seem worth it. So I think it's worth knowing when you dig into things. He was saying, look at all the studies, look at discontinuation, because on the next slide, he's like, when you look at this experience, and this is a very confusing slide, but it's looking at patient-reported outcomes over time, cycle 1, cycle 3, cycle 4, you're only actually looking at the reported outcomes of the patients who stayed on, so you're losing the information as you go over time to say, over time, this was quite tolerable for the people still on it. And so, he really was like, you have to pay attention to how many people are on drug, because that makes a difference. And this particular example he was using is called the Capitello 291 trial. This is the trial that approved a new drug called capivasertib, an AKT inhibitor, first in class, but also looking at that same pathway we were talking about before. And they showed the global quality of life wasn't different between the arms. However, diarrhea was. So, you can kind of have a global thing, and then you can have something specific. You can look over time and say it all looks good over time, but also you're only looking at the people who stayed on, and why did people drop off? We just really need more detail, and that's not always kind of the spin that is shown at studies. And so this particular PRO question, it was in the last 7 days, how bothered are you by the side effect of your cancer? And patients getting the drug had more bother, but it was, I guess, consistent over time. So his final conclusions, and he had some other really good gems in there, but we must learn from those we hope to treat. Otherwise, what are we providing our patients? And patients informed outcomes or patient important outcomes need to be reported rather than just adverse events. A grade 1 adverse event may be different depending on the patient's point of view. So he gave the example, like a young mother having grade 1 nausea who can't take her kid to daycare because she's afraid she's going to vomit and drive is a real significant outcome. But we look at grade 1 and they say, oh, look, it was only 15% versus 4%. So it really is more, and one more point to spur his conversation. This is a big one that gets talked about a lot. Overall survival should not be confused with progression-free intervals. Every study I've just showed you showed its primary endpoint of staying on drug without cancer growing, but really the endpoint most patients care about is I want to live as long as I can with good quality of life. So he is on lots of things posting, and he's an interesting person, and I just really wanted to hear more from him, and I'm sure you would too. Okay, so that's my specific presentations from San Antonio. There are a lot of others I could address, but I did want to mention at Providence, we have lots of clinical studies. We're really passionate about our research. And at any time in our breast portfolio, we have maybe between 20 and 30 studies. Some of them are breast and other things. Some of them are very breast specific. About a third of them are aimed at early stage, 2/3 are aimed at stage 4 disease. So it is the majority of our studies are looking at treatments for metastatic breast cancer. We do get different funding sources. We get about a third from NCI sponsored studies. Those are the ones I'm in charge of. Those come from what we call our cooperative groups. Those are really interesting because those are the big questions everybody's trying to answer. A third come from pharma. Pharma are great because they get us access to the things that are new, but they have a very, very specific agenda and a question they're trying to answer. And that's why I actually like those NCI studies, because it's just smart people with a question, not a person trying to make money. But the pharma studies are really important, and they often can be international. So they're not usually just, Oregon or Portland. A third, though, come from investigators like myself or my colleagues, Dr. Page, Dr. Stanton, Dr. Top. We have studies that we write or we get involved in and we are interested in, and those are great. We like to support each other on that, or we have a Friends Open from Dallas or whatnot. Those are great because you know the person who's behind it. And to learn more, there's a few links. You can always look on clinicaltrials.gov and our website. The last portion of the talk, I'm not sure I have to tell people, y'all, about this. You're the ones living with MBC, but some of the things I think we would generally say is, to think about your health in all ways. So you do need to have another doctor, maybe other than your oncologist, for other things. So if you have any other health conditions, it's important to stay up on that. Sometimes it becomes really labor intensive, doctor intensive to see your oncologist, but it's nice to have a PCP who can help you when there's a thyroid thing or a UTI or something else that's not related to breast cancer, and they may be just super happy to work together with us, discuss your questions with us. We all want to just help you figure out what's the best way to get your next care needs met. On staying healthy, it really does help you continue to be able to live with metastatic breast cancer, to quit smoking if it's something you do, not drink tons of alcohol, some is okay, try to eat really healthy if you can, give your fuel to your body, take a walk, think about exercise. We found so many benefits to exercise, and manage stress. Stress is such a big one, but there are more resources than ever. Thankfully, things like Employment Aid Project provide all sorts of outlets for you. Getting emotional support is really important too. Maybe listening, like tonight, you might have listened in, heard other people talking about their experience joining a support group, either in person or online. Of course, we have them at Providence, but Employment Aid also provides great support. This is just our webpage. We've done it over and over again, but currently it's just showing our breast cancer program, and we have ways you can get information if you're trying to figure out what do we have available at Providence for lots of different things. I think that's the end. So thank you so much for listening. I think we have some good amount of time for questions, and I'm hoping people have interesting things to talk about. So thanks again for your attention. I know it's like a science mumble jumble sometimes.
Thank you.